So it probably doesn't take much motivation, especially for this crowd here. It's well documented that many types of preventative care are underused, and that these kinds of care both have substantial long-run value and often fairly low short-term costs. So if I had been here yesterday and my flight hadn't been canceled, I probably would have seen papers related to medication adherence, diabetes, and hypertension. There's many areas in preventative care where we think it's underused. So potential explanations, some of which we've already heard about today. People could lack information about the value of this care. There could be poor supply of this care, especially in developing contexts. People could have financial constraints. And as Devin spoke about earlier, there could be issues of limited self-control or procrastination in getting these preventative care services. And that's going to be the focus of our study today. Specifically, we're going to be studying the role that commitment devices can play in mitigating these issues of limited self-control and procrastination. So the setting for our study is we're going to run a field experiment, and we're going to study uptake of preventative services to help reduce the onset of hypertension. And so our study takes place in rural areas in Punjab, India, where the average wage is about 230 rupees, or about $4 per day, for those of you who are familiar with India. And hypertension is a big issue here. So 45% of people who are 45 years or older have hypertension, or are at risk for hypertension at least. And only 20% of people who have hypertension have it actively managed it. This is lower than the figure in the US, where this is also obviously an issue. So to study this, we implement a randomized intervention with a partner firm. This partner firm runs weekly health camps devoted to helping hypertensives manage hypertension, giving them treatment plans for hypertension, giving them drugs to help treat hypertension. And the firm that we work with recommends for patients coming in that they make 3 visits into the clinics that they run, where these clinics are set up in these rural areas, in a six-month period. And the purpose of these visits are for diagnosis, for treatment plans, and to get drugs. And so the per visit consult fee, just so you have kind of a price in mind here, is 30 rupees, so about 1/8 of the daily wage, plus the cost of medication and tests. And so this per visit consultation fee you should think about as kind of the baseline in this environment. We ran a randomized intervention where the goal is to increase take-up of preventative services and preventative visits, and essentially to get people to comply with this recommended treatment plan of 3 visits into the clinic in 6 months for the purposes I just described. And so we have a study sample of 1,728 at-risk and hypertensive consumers. We developed this sample across 4 villages using screening and field surveys, where we actually took patients' blood pressure and screened them into this population. We have 5 treatment groups plus a control group for our intervention. The control group is just the baseline setting, where you can go in 3 times and pay 30 rupees per visit, so pay a linear or a fixed fee every time you actually go in. The 5 treatment groups are listed here, and I'll show you them in a graphical form in a second. The first treatment group is just a straight discount. The other 4 treatment groups correspond to different kinds of commitment devices. So one category of commitment devices we call fixed commitment contracts, where we give people the option of choosing a commitment device where you pay the full lump sum for all 3 visits up front, you pay some additional commitment amount, and you get 1/3 of that commitment amount back in each of these 3 cases. And in the fixed case, we determine what that commitment amount is. Okay, so we set this fixed amount. In a flexible case, it's the same setup. The only difference is that now people can decide what this commitment amount is above and beyond kind of paying the lump sum for all 3 visits up front. So you can decide if you want to commit 0 extra rupees, or if you want to commit a larger amount. So in our setting, the control looks like this. If you think about the upfront cost on the left side of this chart, and then the cost per visit on the right side of this chart, in the baseline case, you're just paying 30 rupees per visit, plus the cost of any incremental medications. In the fixed contract case, in our setting, with no discount, you pay 90 upfront, so 30 times 3, so upfront cost for all 3 visits. you pay an additional 45 rupees, which is a commitment amount, and you get 1/3 of that back for each visit you make. So for each visit you come back, you get 15 rupees back. In the fixed case with the bundled discount, your upfront cost is lower, but your commitment amount is the same. And so the purpose of this is obviously to shift people into these treatments on the margin, okay? Or into the commitment device. In the flexible case, it's similar in that you pay 90 up front, but now you have a commitment amount which you add up front, which is 3 times M, and M is an amount that you choose as a consumer, which is greater than or equal to 0. So, and then you get M back on each subsequent visit. And this is also bundled with the discount. So for treatments with commitment contracts, either with or without discounts, discount treatment in the control group. And so the key questions we're asking kind of fit into 3 buckets. The first bucket is studying commitment contract take-up. So how many people take up these devices? Are people more likely to take up the flexible device as opposed to the device where we pre-specify the commitment amount? How much do people actually commit in the flexible contracts, and what kind of people take that up? Kind of speaking to the heterogeneity question, some of which has come up already. The second question is, does the option, so remember in these treatments, you have the option to choose this. We're not forcing you into this. Does the option to choose this increase the actual service use, which is obviously kind of the question in some sense we're most interested in. And here there's sub-questions about if you have the flexible device, are you more or less likely to actually follow through and use the commitment and go to the doctor, etc. Finally, a third question is, do people actually benefit from these contracts, okay? And this deals with the trade-off that manifests between kind of people not following through on the contract and losing money from paying this lump sum up front versus any potential value from health service increases. From a take-up standpoint, this is what we find. So this is just for the, this is contract take-up. This is for the 4 treatment groups of fixed contract, no discount, fixed contract, discount, etc. And we find 2 results. The first result is that people are more likely to take up the flexible contract where they pre-specify the commitment amount. The second result is that people are more likely, in our setting, substantially more likely actually to take up the both either the fixed or the flexible contract when it's bundled with the discount up front. Okay? In the flexible commitment contract where people actually choose the contributions up front, most people actually add on 0, so actually add on much less than the fixed contract where we pre-specify this amount. But they're still paying the full lump sum up front. So this is a case where most people are basically choosing to pay for the 3 visits up front but not pay anything incremental on the margin. And you can see that some proportion of people contribute a substantially larger amount, so over 20 rupees. In terms of actually follow-through of the preventative healthcare visits, the top part of this chart shows follow-through among takers. And here, follow-through means that you visit at least once in the post period when you visit the physician. It doesn't specify that you've gone all 3 times, okay? And so in the top group, you can see that if you sign up for the contract, you're much more likely to go. And you're much more likely to go in the fixed contract. Now this could be for 2 reasons. This could be both because the fixed contract is giving you the incentive to go more and increasing, in a commitment style way, increasing your desire to go. But it could also be that people who select into these contracts are people who are sicker already, or who are more likely to go ahead of time. And so among the sample and the full sample, which is kind of the right comparison to think about, if you look at this, you can see that the discount treatments actually increase take-up. It's actually not listed here, but the discount treatments increase take-up relative to the control groups, but the commitment contract treatments really don't in our setting. And so these charts on the y-axis show the percentage of sample without a visit as a hazard rate over the 6 months after the treatment since the baseline. The black line here is the discount group. The dashed line is the full price group bundled across these treatments. And so you can see that the discounts have a material impact here in increasing take-up of the preventative visits. This chart shows take-up versus no take-up. So did you take up a commitment contract or did you not? And in this case, you can see that the people who take it up use it a lot more. But again, this could be because of a selection effect. So then we look at this chart, which basically shows control group any fixed commitment contract offer, so just being offered in the treatment group, and any flexible commitment contract offer. And here you can see that these lines actually are very close to one another. So these results, at least in our specific setting, suggest that the discounts matter in terms of actually increasing service take-up, but the commitment devices were not seeing kind of any specific increase in take-up. One of the purposes of this study, once we implement this randomized intervention, is that we then want to study the mechanisms underlying. So why, much in the mold of Devin's talk earlier, why are people behaving in this way? And specifically in our setting, we're finding that a lot of people are contributing money to these commitment devices, but then not following through, okay, on those devices. And so, with the time I have today, I'm not going to be able to go through kind of the detail of what we're doing here, but I did want to motivate this because we are using the randomized intervention and kind of the specific features of this intervention to estimate a beta-delta model where we're specifically trying to study both what's the degree of self-control and commitment problems that people have, and what's the degree of sophistication that people have about these things. So in the model we're studying, we have people choosing the commitment contracts at t=0, people deciding to make the preventative health behavior at t=1, and then the health outcome realized at t=2. And from an identification standpoint in this model, the choice you make of the commitment contract up front tells us something about what you think your commitment problems are like, so what your beta hat is in the context of a beta-delta model of sophistication issues. And then the sequence of decisions, so the commitment contract choice you make, plus whether you actually follow through about that, tells us something about the combined beta hat, which is what you think about your self-control issues, and the beta, which is your actual level of self-control issues that you manifest in period 1. So this structural estimation of this is ongoing work, and obviously is something that we're excited about. So to wrap up, the kind of structural work where we're really thinking about the micro foundations for commitment issues is still ongoing, but there we're excited to kind of learn more about kind of the types in the population who are sophisticated, who are not sophisticated, who follow through on these commitment devices, who don't. One thing which came up earlier that we're excited to work on here is we're really excited to look at commitment in the context of uncertainty, which was brought up earlier. So specifically, this is a new product for many of the people in the setting, and we're interested to think about how people commit to learning about using this product. So commit in an environment with uncertainty. And that's it.